Hello everyone, this is Professor Williamson. This presentation will focus on the Chapter 17 non-graded exercises. For some of them, you will be noted or asked to post your thoughts to the course discussion board, and the correct answers will be given to you after we have had some time as a class to discuss them. So if we look at the exercises in the end of the urinary chapter, the first 5 are multiple choice or fill in the blank. The first one is the exercise statement states, ablation of a renal tumor is performed. Which root operation is coded to describe the intent of this procedure? You have 4 options given to you in the textbook. You have destruction, excision, extraction, and resection. In order to make your selection from those 4 possibilities, you do have to understand what they mean by the word ablation. Ablation is a type of destruction of tissue. There's different ways of doing ablation. You can do it via heat, which is typically referred to as radiofrequency. You can do it with cold, called cryoablation, or they can use lasers or chemicals, which help to do those types of heat or cold ablation. So ablation by definition is destroying of tissue, and typically, or not typically, ablation also means that it's not done with a scalpel. There's no cutting other than the laser type cutting, but there's no knife used. They're using some type of energy or some type of an agent, such as a chemical agent. So the correct choice out of the 4 is A, destruction. For the next one, the next question in your textbook, it says code 0T2BX0Z describes the procedure of changing a what? You obviously can go to the 0T2 table, and you note that that relates to the root operation of change. And if you look at the various values for the rest of the parts of that code, you find that the right answer would be urinary catheter or drainage device. You do need to use the 0T2 table in order to be able to answer this particular code, so you need to use your coding manual. The number 3, the surgeon performs an open urinary diversion of the left ureter using an ileal conduit to the skin and a laser removal of a left ureteral lesion. How is this coded? And they give you 4 options. Before we even look at the options, we need to look at that statement. You have the physician doing a diversion and also removing a lesion. So based on our knowledge, we should know or think about the possibility that we're going to have 2 codes because we have 2 different root operations. So then when we look at the options that they provided for us, there's only 2 options, A and C, that even give us the possibility of 2 codes. So we should code this. You could spend the time and go look at the 0T1 table, which relates to the first option here in A, and then go to the 0T5 table. If you also note, the second code for both A and C is the same. The only difference is this first code. So you definitely want to double check if you're not going to code it straight out, which is typically a faster route, meaning you go through the root operation, you figure out what the root operation are, you go to the index, the alpha index, go through those steps. But if you want to go the other way, you're going to have to look at the 0T1 table and the 0T5 table. Make sure those are your options. They have to be to some degree. Make sure you want to use the 0T5 table. And then check your codes, making sure all the character values correspond to the information given. And when you do that, you figure out that the best answer is C. Or you can determine based on the urinary diversion that the root operation would be bypassed, and then you would index bypass ureter in your alpha index, and you go to that table. And of course, laser removal, again, laser is key. Laser removal relates to the root operation of destruction, and you would index in the alpha destruction, and then ureter in your alpha index. And you would end up at the same answer. But it is typically faster from a time standpoint to actually code the situation, because I will tell you one tip on the national exam, it's not going to be this, they're not going to use the same code twice. They're also not going to use the same tables. Basically using 0T1 and 0T5 in this answer. So they're going to make it a little bit more challenging, that you would have to look up multiple tables, not just two, even if you chose to look up every single code that was provided to you in the option. The next question is a fill in the blank. It states that a Marchetta-Krantz urethral suspension operation is coded with the root operation of what? In your textbook in chapter 17, they talk about suspension procedures, that they are focused on repositioning an organ back into its correct anatomical position. If you Google this eponym, this Marchetta-Krantz, you will find what it is in terms of a procedure, and it is moving pieces of the urinary system back into its normal position, so that equates to the root operation of reposition. Number 5, a suprapubic aspiration of the bladder is performed. Which approach value is assigned? So you do have to understand what that procedure means. We have the word aspiration. Again, if you Google, I use Google search a lot. You could also use Bing, your favorite search engine, whatever that may be. If you Google or search engine use your suprapubic aspirations, you will find out that this is a way to get a sterile urine specimen. They go in through the lower abdominal area and they aspirate in a needle a specimen of urine. So the word aspiration equates to a needle. A needle goes back to chapter 1 when they talk about different surgical approaches, and that then equates to a percutaneous surgical approach. Then if we move to the procedure statements that are in your textbook, for the first one, the patient is undergoing an exploratory laparotomy because he or she presented with severe urinary hemorrhage. The procedure found an extensive adenocarcinoma of the left kidney with metastasis to the left lower lobe of the lung, the great vessels, and the lateral diaphragm. The tumor could not be removed, and therefore the left ureter was surgically ligated to prevent further urinary hemorrhage. So they went in, patients having blood in their urine to a severe extent, or is basically bleeding blood, so to speak. It's a severe urinary hemorrhage. You may not even have any urine in her elimination. It could be just total blood. They find this patient has extensive cancer. They can't remove it, or perhaps the urologist is not qualified to do all of this excision of the tumor. So he or she, the surgeon, decides to ligate the patient's left ureter. The patient has a right one also, of course. What does that mean? When they use the word ligation, what does that mean? Anatomically, or if you look it up in a medical dictionary, the word ligation is defined as closing off a blood vessel or a tube or a lumen in a body with a ligature or a clip. So they're closing it off totally. And ICD-10 PCS world, that relates to the root operation of occlusion. So you're going to index the main term of occlusion, then the anatomy. It is ureter in this case. Then you are given 0TL7 in the alpha. You move to the 0TL7 table. You then have, or 0TL table, you have the body part value, which is 7. Then you have to determine the surgical approach. In the clinical information, it said it was done via exploratory laparotomy. Otomy, O-T-O-M-Y, equates to an open incision. So they didn't do this endoscopically. They went in through the patient's abdominal cavity and they made an incision. And there's also no documentation of using an endoscope or a cystoscope. He also talks about the fact that they saw her diaphragm, or the patient's diaphragm was visualized because they saw the metastases. They wouldn't be able to see someone's diaphragm if they went up through the urethra. So the final code is 0TL70ZZ. The surgical approach is open via use of the word laparotomy, and also the extra information. We're talking about where the metastasis was seen. The next one, the patient has recurrent urethral strictures, where a mediotomy, there's that word otomy again, or part of a word otomy. A mediotomy was performed due to stricture. Then a scope was advanced through the urethra into the bladder, where a bladder neck contracture was found. The contracture was incised. So this patient had 2 pieces of anatomy of the urinary system worked on. They had the urethra and their bladder neck. Also, they did a mediotomy, which is an open procedure, and then they did a endoscope. So we have 2 different surgical approaches. We have 2 different pieces of anatomy. Also, you should know what a contracture means. The physician in this clinical statement talks about a bladder neck contracture. Contracture in the medical dictionary is defined as a condition of shortening or hardening causing a deformity. So if we're going to focus on the first part of the procedure, which was the mediotomy, which was focused on the urethra, what was the intention? This patient has a narrowing and we want to open it up. So our root operation is dilation. We're going to index in our alpha index of our ICD-10 PCS coding manual dilation, then urethra. We're given 0T7D. Again, that word otomy in mediotomy equates to a cutting into. Therefore, our surgical approach is open. No device was left in this patient. They're trying to open up their anatomy. They're not going to leave anything in there. The patient's having a stricture or a contraction of their anatomy. No device was left in, no qualifier. Our final code for the work on the urethra, which was noted as a mediotomy, is 0T7D0ZZ. Then we also have to code the use of the scope. So after the mediotomy, the surgeon then inserts a endoscope. He just calls it a scope. Same root operation, different piece of anatomy. It's bladder neck, and there is a different device. In this case, it wasn't open. They didn't cut into the patient's bladder. They used a cystoscope to get to the patient's bladder neck. The bladder neck is that more funnel-like point at the end of your bladder, looking at it from a down standpoint, looking down, going into your urethra. So we're going to index the main term of dilation. Then we're going to index the specific anatomy of bladder neck, not just bladder, because anatomically in this coding system, and I believe they talk about that in your textbook chapter, we have a distinct character value given to the body part of bladder neck versus just the bladder. In table 17.1, they talk about They give you a description and they denote that you have separate body part values for bladder, neck. So we're going to index dilation, bladder, neck. In the alpha index, we're given 0T7C. Again, this was done with an endoscope or a scope through a natural opening. It states in the clinical information a scope was advanced through the urethra into the bladder. That equates to 8 for our surgical approach. No device was left in, no qualifier. Our final code for that portion of the procedure is 0T7C8ZZ. So for this procedure, we have two codes. We have this code and we have the one on the previous slide. This one. For number 3, the patient is having an ESWL or an extracorporeal shockwave lithotripsy of a large bladder stone. Another word for a bladder stone is also a bladder calculus. As noted in your textbook chapter, lithotripsy equates to fragmentation or breaking up of a stone. Also, it's helpful to note that when they do a lithotripsy, they're not really touching the patient. This is all done external to the patient. So we're going to index the word fragmentation, then bladder. We're given 0TFB in the alpha. Surgical approach is external, no device, no qualifier. Our final code is 0TFBXZZ. Number 4, the patient's having a right kidney transplant from a matched donor. It does state matched donor in the clinical information. It doesn't say it's twin. It just says it's a matched donor, meaning it's from another human being. It's also noted that the kidney that's being transplanted came from the donor's right side. So it's a right kidney being put into this patient's body. Where it's being put in this patient's body, the right side or the left side, has no impact on our code assignment. In this case, we're going to index the root operation of transplantation, kidney right, because that's the organ that's being put into this patient, is a right kidney from the donor. We're given 0TY00Z in the alpha. That is not a complete ICD-10 PCS code. That particular code only has 6 character values. We move to the 0TY table. We have 3 options for our qualifier value. We have 0, 1, and 2. 0 is for allogenic, 1 is for synergenic, and 2 is for zeoplastic. This kidney came from another human being, but it is not identified that that human being was a twin sibling. We're going to choose 0 for our final character value. Our final code for a right kidney transplant from a matched donor is 0TY00Z0. Number 5, we have a suturing of a bladder laceration open. The anatomy is the bladder. The surgical approach in the clinical statement is given to us as open. They're using sutures to repair an open wound that wasn't surgically created in a patient's bladder. The root operation is repair. We're going to index repair, then bladder. We're given 0TQB in the alpha. We move to the 0TQ table. We already have the body part value. We already were told in the clinical statement that it was an open surgical approach. We're going to choose 0 for our surgical approach value. No qualifier, no device. Our final code is 0TQB0ZZ. Number 6, destruction of a urethral tumor, endoscopic. The word destruction relates to how this was done. The approach is noted in the clinical statement as endoscopic, which means with an endoscope. The root operation is destruction. We're going to index destruction, then urethra. We're given 0T5D in the alpha. We move to the 0T5 table. We have the body part value of D from the alpha index. We're going to choose our surgical approach. It was noted as endoscopic. It doesn't say it was done any other way. The most common way to get to your urinary structures is through your urethra. So we're going to choose 8 for endoscopic approach, natural opening, no device, no qualifier. Our final code is 0T5D8ZZ. Number 7, patient is having a change of a ureterostomy tube. Root operation is change. You're going to index change and then ureter. You're given 0T29X in the alpha. You move to the 0T2 table. There's no documentation given to us that this patient's skin was cut. Just states that this tube was changed out. We have no documentation that there was any type of puncture, anything. So we're going to choose X for our surgical approach, which is external. So they basically just pulled the tube out and put a new one in. Device character value is going to be a positive thing because this is a ureterostomy tube. What's the intention of a ureterostomy? To reroute urine. We talked about that in the lecture. The most common reason a patient would have a ureterostomy tube is typically you'll see them in children who have had congenital defect or perhaps a major abdominal surgery. So they're rerouting their urination process to a tube, and then that tube goes outside of their body. Your urine is going to go into a bag for collection. So we're going to reflect a positive value of 0 because it's a drainage device. A ureterostomy tube is draining urine. Z, no qualifier. Final code is 0T29X0Z. Number 8, open adhesionolysis of the left ureter. This patient has internal adhesions in their left ureter. Adhesions are overgrowth, basically, of tissue that can cause blockage. Typically, people get adhesions after having surgery in a certain area. So in this situation, the physician is going in and he's cutting into these adhesions to open up the space of this tubular organ called a ureter. And it happens that you have 2 of them, one on the right, one on the left. In this particular operation, the physician is only working on the left side. It states it was open. It wasn't done via cystoscopy or any kind of endoscope. So what is the intention of doing this? What is the intention of going in and cutting into these adhesions? Is to open up the space. And that relates to the root operation of release. So we're going to index release, then the anatomy. We get 0Tn7. We move to the 0Tn table. We have our body part value. Our next choice is for surgical approach. It was documented in our clinical information as open. We choose 0 at that table, at that row. There's no options other than Z for device and qualifier. So our final code is 0Tn70ZZ. Number 9 is open insertion of an inflatable bladder neck sphincter. The surgical approach is documented for us as open. The location again is specifically the bladder neck, not just the bladder. The root operation is insertion. We're going to index insertion of device in, then bladder neck. We're given 0THC. We choose 0 for open surgical approach based on our clinical information. At that particular row, we do have device character value, and there's only one option, it's L. And then for qualifier, the only one option is Z. Our final code is 0THC0LZ. Number 10 is a periurethral bladder neck suspension utilizing a suture open. If you go back to chapter 17, there's discussion of suspension procedures relate to repositioning, moving something back into its normal position. We're going to index reposition, bladder neck, again, very specific, not just bladder, bladder neck. We're given 0TSC in the alpha index. We move to the 0TS table. We have our body part value already. We just choose our surgical approach next. Is documented in our clinical information as open, which is 0. No device, no qualifier at that row for that table. Our final code for this bladder neck suspension utilizing a specific type of suture, open surgical approach, 0TSC0ZZ. Moving on to the case studies. The first one, the physician documentation of preoperative and postoperative diagnosis are the same. It's a granular hypospadiasis. This 11-month-old child is coming in for a surgery to correct this condition. It helps if you understand what this condition is. There's different kinds of hypospadiasis, but this is a normal male penis with the urethra and the opening at the tip. If it's not in that normal position, it's this condition. But there's different kinds, different locations that could end up coming out of. So when we look at the clinical information under the word operative note, this is a condition of the urethra. This is not a condition technically where there's something wrong with the penis. It's actually something is wrong with the urethra. It's coming out in the wrong location. In the clinical statement in the operative report, it states the urethra mucosa was then advanced with sutures such that the entire bridge of tissue and the urethra was in a normal granular position. So clinically, surgically, the surgeon is working on the urethra, which is a body part. So we are then looking for our intention, our objective. The objective is to move the opening of the urethra. And these are the different types of this condition. This child has the granular one, so it's here at the back of the tip of the penis instead of at the very top. There's all different kinds. And obviously the further down it goes, the more work is going to require surgically to move it up to where it should be. It should be here. So what are we doing? The surgeon is moving the opening of the urethra. That equates to the root operation of reposition. We're going to index reposition, then the anatomy, urethra. We're given 0TSD in the alpha. You move to the 0TS table, and you are given D as the body part value. I will change that because the font I used here made this look like a lowercase o. It should be, or lowercase 0 should be a 0. We're given the body part value of D in the alpha. In the clinical information, we're looking for our surgical approach. Was this done with an endoscope? Most likely not, but we don't have to guess. It says in the clinical information a deep back plate incision was made after a tourniquet was applied, and the urothelium, talk about the tissue of the urethra, was advanced to the epithelium of the glands with interrupted 7.0 vicral sutures. So this was done via an open surgical approach. Was any device left in the patient? No. Was there a device there when the surgeon started the procedure? No. At that table, at that row, there's no options for qualifier other than Z. Our final code is 0TSD. 0. Surgical approach is open, ZZ. Number 2, case study number 2, you're going to post to the discussion board in this class. Moving on to case study number 3. This patient has a history of right ureteral stone. He already has, when he is wheeled into the operating room, the patient already has a stent in his body, his or her body. The focus of this procedure is to remove this stent. It states in the clinical information, right extraction of JJ urethral stent and right ureteroscopy. So we're looking for clinical information. It states in the clinical information under procedure in the textbook, it states a 10 French cystoscope was introduced into the urethra and advanced to the bladder. The right ureteral stent was identified and was removed using grasping forceps. So we know what was done, where it was done, and how it was done. They pulled out this ureteral stent. They did it via cystoscopy, which is an endoscope, and forceps, and it was the ureteral stent. What was the objective? To remove this stent. The root operation is removal. We're going to index the word removal of device from ureter. U-R-E-T-E-R, the one without the H. We're given 0 TPN, 0 TP9 in the alpha index. This was done with an endoscope, also called a cystoscope. This is a picture of a cystoscope. This happens to be what it would look like going into a female body. So the surgical approach is 8 for a surgical approach via natural opening endoscopic. Was a device left in? No. Was a device already there? Yes. They went in to get a ureteral stent. It had already been in the patient's body. So we are going to reflect a positive value of D for intraluminal device. Remember your ureters, you have 2 of them, those 2 tubes coming down off your kidneys. They're tubular, muscular, tubular structures. Tube and luminal are the same synonyms. We're going to choose D for our intraluminal device, which is being removed in this case. Z, no qualifier. Our final code is 0TP98DZ. The fact that this was done and they had to go look, check things out first, which equates to an inspection, is not coded separately. That's part of this procedure. The intention, when the patient was wheeled into the OR, the intention was to remove this stent. Yes, the physician looked around with the cystoscope, and the cystoscope was also used to get to this device they pulled out. But the fact that the physician wasn't intending to just look around. It was a purposeful plan when the surgery began, and that's where our root operation lies. So we are not coding the cystoscopy by itself separately. We're reflecting the cystoscopy in our surgical approach value of 8 in our final code. So there's only one code assigned, and that's 0TP98DZ. Number 5, the patient has urinary reflux, has a lot of nocturnal bedwetting and accidents. This could be a younger patient, such as a child. The physician is going in and is putting in a substance. He's injecting a substance called Duflux in the clinical information. In this case, in the operative report under description of procedure, it states a 20 gauge endoscopic needle was passed via the working port of the cystoscope, and 1.1 cc's of Duflux was placed in the left subureteric space. Then 0.8 cc's of Duflux was placed in the right subureteric space. So they did this on both sides. Remember, you have two ureters, one off of each kidney. The surgeon placed this substance in both ureters. If you look at you Google Duflux injection, you'll find, and here's the reference, you'll find that this is a substance. It's a gel-like substance. It's not a device, it's a substance. So it's not going to be reflected as a positive value on our device character value. So what was the intention? Why were they putting this substance into this patient? What's the patient's issue? The patient is having voiding dysfunction, nocturnal enuresis, and accidents. So they're putting it in for restriction. He has a vesicoureteral reflux, grade 3. So our main term is restriction, then the anatomy. When we go that pathway in the alpha index, we find that we're given two parts of a code. We're given 0TV7 for left and 0TV6 for right. That's a big clue that we're going to have to, in this case, because this substance was injected on both sides, the right and the left ureter, that we're going to have to use two codes because we don't have the option of bilateral. So we move to the 0TV table. We know based on our clinical information that this was done via a rigid cystoscope, which was passed into the patient's body via the patient's urethra, which is a natural opening. So we're going to choose 8 for our 8 for our surgical approach, which is a natural opening endoscopic. No device, because this is not a device, it was a substance, and no qualifier. So we end up with two codes. We have 0TV78ZZ for the injection of the left ureter and 0TV68ZZ for the right. Number 7, the patient has a large bladder stone. States in the procedure, in the case study under the word procedure, it states the patient was prepped and draped in the usual manner. An incision was made in the suprapubic area. The incision was carried down to the subcutaneous tissue. The fascia was nicked, and the incision was carried up and down using the Mayo scissors. The rectus muscle was separated. The area of the bladder was identified. The bladder was irrigated. There was an incision made in the bladder area. The incision was gated to proper. The incision was thickened by the previous inflammatory reaction. Incision was carried down through and into the bladder. The bladder was opened, and there was a very large bladder stone found. So this is an open surgical approach. The surgeon documents how much work he had to do to get down into this patient's body. He ran into some issues, but that doesn't impact our code assignment. But this identifies how much depth he had to go through, and that this is truly an open incision. There's no mention of an endoscope. There's no mention about going through your urethra. He states at the very top of the second sentence that an incision was made in the suprapubic area. So the surgical approach is open. Bladder is the body part. And also after they removed this stone, he looked around. That's part of the clinical process. We're not coding any type of inspection of the bladder. He also had to close up the incision that he made into the bladder. We're not coding that separately. The surgeon made the incision into the bladder. He has to close it up. That's part of the code. Then the physician put in a Jackson-Pratt drain. That is considered an incidental. Often when they have to do these very in-depth in terms of getting into the body, they have to cut through multiple layers, cut through organs to get to. They're going to put in a Jackson-Pratt drain because as the body heals, there may be some residual blood left in there. And the body, even though at the time doesn't recognize once the patient's blood flow and the patient is awake, their blood flow is going to start causing inflammation. There was some trauma down there, and that's going to breed tissue swelling, and they want to drain that excess fluid out the body. So the Jackson-Pratt drain is not coded separately. Chapter 1, they talk about incidental drains, and this will be considered an incidental drain. It's common when patients have these type of depth into their body procedures. You also see Jackson-Pratt drains done a lot when patients have GI procedures such as bowel procedures or colon procedures. So, what is our root operation? What was done? This patient had a stone removed from their bladder. What is a stone? A stone is solid matter. Root operation is extirpation. We're going to index extirpation. Then bladder, we're given 0 TCB in the alpha. You move to the 0 TC table. You have your body part value of B. Your surgical approach is open. 0 is the value for that. There was no device left in the patient, no qualifier. We're not coding the drain. That's not considered a device that's of significance. Our final code for this procedure is 0 TCB 0 ZZ. And that's the only code. There's no other code. So, now's the time for you to go and code case studies 2, 4, 6, and 8. They are not part of any graded assignment in this class. Once you have coded them, you're going to post your codes to the discussion board. Remember, you can do an audio or a video, or you can type your codes in, and you will be given the opportunity after some discussion to see the final correct answers for those particular cases. Thanks for listening.